Hello, everyone, and welcome to today's webinar, Achieving High Reliability Growth and Nutrition in the NICU with Dr. Jay Kim. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. You can submit your text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during his presentation. We will collect them and address them during the Q&A session at the end of the presentation. A handout is available, so please locate in your panel the handout section and be sure to download that prior to the event ending. Today's webinar is being recorded and will be made available on Medila University and Medila's Education for Lactation Professionals YouTube channel. Also, regarding continuing education certificates, they will be sent out to your email address that you registered with, and they should go out by Friday of this week. I would now like to introduce Dr. Jay Kim. Dr. Jay Kim is Institute Co-Director of the Perinatal Institute, Division Director of Neonatology at Cincinnati Children's Hospital Medical Center, and Professor of Pediatrics at the University of Cincinnati College of Medicine. His special areas of clinical and research interests include neonatal nutrition, neonatal bowel injury, bedside ultrasound, family-centered care, and resuscitation. He is the co-founder of the San Diego Mothers Milk Bank and the innovative, nationally recognized multidisciplinary program to advance premature infant nutrition called SPIN, Supporting Premature Infant Nutrition. He is the co-author of the book Best Medicine, Human Milk in the NICU. He is a past member of the AAP Committee on Nutrition. Dr. Kim?
Great, thank you very much, Wendy, for the kind introduction. It's great to be part of this webinar series. My task is to try to cover a quality lens as we look at neonatal nutrition. So I'm going to try to spend the first 40 to 45 minutes talking about this and leave hopefully it's ample time to deal with a Q&A at the end. So here are my trying to get the slide to advance.
Sorry, try that circle with your mouse and click, and then do the arrow key. And if it doesn't work, I can advance. It's not working, is it?
Not working all of a sudden.
That is peculiar. Let me advance for you, and we'll try it again after.
Okay. So these are my disclosures. And then next slide.
There you go.
I think that worked. Okay. All right. So over this webinar, I'm going to try to cover some highlights around best practices, and in particular, give you a perspective of how one can use quality improvement measures, and in particular, looking in your own system for ways to improve the reliability of your system. And a way I'll do that is I'll show sort of the overall nutritional epochs that or epochs over the course of the hospital stay, and look at some of the ways that we can improve that. So thinking through this seminar, I want you to be thinking about your own system and how your own system could be benefited, and where are you working on in order to make improvements. So in the sort of just after the mid 2000s, about 2007, we, Lisa Stellwagen and myself, worked on a 10-step approach to supporting premature infant nutrition. And really the driver of this at that time was to try to bring two communities together, the nutrition community and the lactation community. And what evolved over time was this recognition that the OT and the PT and the speech therapists also work on the oral feeding, which is also a really critical piece of this. So thinking about that triad, what are the sort of the high points of being able to develop a system that could address these areas, important areas, to be able to grow babies the best, and with human milk being the center of all that. And that's where the effort initially came about. So I'm going to highlight, as we talk, some of these points and how we worked on solutions to be able to move each of those along the way. Many resources are out there. This is one that I was invited to participate in many years ago when I used to be in San Diego in California. And this is the build of a nutrition toolkit. And I really like toolkits because toolkits allow for groups to identify an area of interest for them and to be able to really jump onto the benefits of other people's work. And in quality improvement, we talk about stealing shamelessly, taking other people's protocols, other people's documentation, policies, and being able to leverage that as they go forward, if it's a feeding algorithm or what have you, as well as getting some of the verbiage or the logic or the rationale why you want to introduce a particular change in practice. So this is been a toolkit that we had for a number of years in California, and it's a very popular one because it has a lot of these tools that are available to anyone who has access to the CPQCC site, which is open to the public. So I encourage you to take a look at that. And the essence of quality improvement science is really to try to get the most bang for your buck, or what often in other cultures talk about the maximum effect with the minimum effort. We're trying to get change to happen in a systematic way with a proper methodology behind it, knowing that habits are hard to break. And we are just like everyone else, difficult to change because we're hardwired as such. So one of the challenges that we face in medicine is this gap, this implementation gap. So from the time when we have enough or reasonable scientific evidence to when we actually execute and have it in place for clinical care, this gap is not measured in days or months, but it's measured in years, and can be as high as 17 years as sort of the average from getting solid evidence to implementation. So this is the challenge that we face when we're thinking about quality improvement. It's not the gap where we don't have enough evidence. It's really moving the needle across. And when we see the human factor, we know that when new things come to us, we all fall into one of these categories. We either really love that idea and will make the change and come early as an early adopter, or on the flip side, you'll tend to be a laggard because you're afraid or worried or there's concerns regarding that change. And so this is important to recognize when you're trying to implement change in a group, that people are going to fall into different categories here. The majority sit somewhere in the middle, but it's important to recognize that not everyone moves together at the same time. And some of the factors that influence people are not just medical evidence. In fact, medical evidence is probably one of the lower ones. So thinking about how your system, what motivates people to change is important. And standardization of care is really critical. So I said that evidence, once you have evidence, you can move to implementation. We also have many situations, and neonatal nutrition is one of the places where sometimes the evidence isn't that great. And this is a key point, is that standardizing your care, even when the evidence is not is super strong, is really critical. And there's examples after examples that standardizing your practice is in of itself the better care model. And this is something that we have, and many others have applied in the nutrition field when we're thinking about how we deliver nutrition. How do we set up caloric targets or nutrient targets, and how do we set up goals for growth? Developing systems to standardize the care so that we are able to provide consistency, particularly when we're talking about a vulnerable gut who may be much more vulnerable to damage, and being able to take out those outliers, those practices that put stress on the GI tract and on the baby. And so a system approach is really important. So as you get deeper and deeper wanting to change, it's really helpful for you to look at your own system. If we're taking a look at how your own individual unit addresses neonatal nutrition, or how it addresses neonatal intake of human milk, understanding how your system functions, what's the psychology behind the decisions that are made and why certain practices have been put in place, as well as recognizing what is causing variation in your system. Is it the attending of the day, different providers add in extra variation, or is the system designed to create and allow for too much variation? And then variation is noise, and variation makes it much, much harder for you to see change and to actually implement and know that the implementation makes a difference. So the more consistent your background is, the more consistent your system is, if you want to make a change, you'll be able to see it a lot better if you can remove some of that excessive noise. So understanding your system, what's the patient population, who are you talking about, who's involved, and then really narrow down, we'll talk more about this, but what is the problem that you're trying to solve, and be very precise about sort of the time limits of how you're going to solve it. And then breaking down everything into processes. That's something that I've recognized this over and over again, is that in order to solve an area of active change that is required, you need to understand your processes. So being able to sort of deconstruct an area of practice and looking at the process steps that make up that area is really helpful, because then you can dial into one process and then address that one process specifically. And then be very careful about not swallowing the whale and being able to focus really on short-term gains as well as the long game and the longer picture. So in California, we completed a few years ago this Grow Babies Grow collaborative. Really was a classic IHI model, which took teams. I think in this case it was about 22 teams together, activated champions in different units, and asked them to try to map out their own nutrition journey for their preterm babies, and then using that roadmap, identify areas by themselves where they would want to control and be more consistent in order for the end result to grow babies better. And one of the tools that we used was this sort of roadmap, which I really like this slide, to help frame the shared mental model for people. In other words, to take that nutrition journey from the beginning, when the baby is born and they're being fed parental nutrition, to the transition period from parental to enteral nutrition to enteral advancement or feeding advancement, to when they're starting to get acclimatized oral feeding, and then the holy grail to get them to actually start to breastfeed appropriately, and then have a successful launch to home at the end of all that journey. And then the lactation journey on the bottom, also to be able to map out that journey in different phases or different epochs for people to then target their improvement or their implementations. And what we found with the groups in California, the collaborative, many people gravitated towards the front, and really because a lot of the data and the evidence seem to support standardizing practice up there. And I only, which is fine, but I want you to recognize that those first 2 or 3 weeks of life is not the entire journey of these babies. And so thinking about in your own unit what that journey map looks like, and recognizing, as you can see with the sort of the check mark line in the background, that this is the sort of the trajectory of a baby initially losing weight and then gaining weight over time, that there's a long period of time where a baby is growing and attempting to grow optimally. So really paying attention to the intermediate and the later periods of feeding and growing are also really important to act on in terms of standardizing practice and implementing change. But not easy, because it's a long journey and most of the evidence seems to be on the front end, and that's really where a lot had put their emphasis. And at the end of that collaborative, the data is just getting published now. Really, we did not see major changes on the ultimate outcomes, but saw significant improvement in the process steps. And once people were able to focus on a process, they were able to demonstrate improvement in that particular process. So I'm going to go through a few slides to give you a sense of what it's necessary to make change. And this is one of the slides I like to use, and that is to try to send a strong message so that there's a paradigm shift or a communication shift so that people frame something differently, and people can say, I got it. It's a eureka moment. So it certainly was a eureka moment for me when you think about human milk being like a tissue, a liquid tissue, and it's classified as a tissue. And what liquid tissue do we know? And that is blood. And so thinking about human milk is like blood, because it has cellular components and all these other ingredients, including bioactive components, as well as the nutrition, is a huge game changer when you're framing that. So taking these kind of messages and planting them in your education material and planting them as part of your strategy to get people to think out of the box and against what their previous thinking is really, really critical. Also thinking about how human milk has cellular components, and these cellular components are both human and microbial. So we now know that there are a lot of probiotic agents that are in there, but we also know that there are immune cells of varying types, as well as even stem cells that are present in human milk. And that provides an additional layer of immune protection to babies who are taking human milk directly from the breast. Once you put it in a bottle and the bottle sits for a while, a lot of these cells stick to the side or can die, and definitely by freezing, there's loss of mammalian cells. The probiotics, on the other hand, do not get destroyed by freezing, but if you, as we'll talk later about donor milk, there are other processes like heat treatment that will destroy those bacteria. So it's important to know. So again, part of the messaging around human milk is recognition that unlike formula, there are hundreds of different bioactive components, and these bioactive components have antimicrobial factors, there are hormones, there's growth factors of varying nature that stimulate the gut and the immune system, there are anti-inflammatory components, transporters, and even digestive enzymes that are designed to auto-digest the milk. So sending a message of differentiation like this is a really important, powerful way to help people reframe how they look at human milk going beyond just the nutrition. And then referencing also the important benefit of breastfeeding in both its ability to affect the long-term outcome of babies, and we're mostly talking about preterm babies, but we know that breastfeeding is powerful for all these benefits to even healthy term babies, and also the benefit that is present to the mother. Are other messages that go on top of the benefits to the preterm infant when we're talking about human milk. And then when we think about something really impactful like death or mortality, and we usually typically say that human milk is beneficial for reducing infant mortality in developing countries, in addition to other morbidities like sepsis or diarrhea, we also know that there are data that support that mortality is improved even in the developed countries like the US. At all-cause mortalities, this is the sudden infant death, in the preterm population, NEC and sepsis are impacted by human milk. So taking a very strong outcome, powerful outcome, and making that message is really important. And then we narrow down to the preterm infant, as I mentioned, the reduction in NEC, but also powerful benefits to cognitive development. So more brain capacity, that's huge in our preterm population that have risk, as we know. reduction in sepsis, and then changing in the microbiome, which is a real key message that we are now trying to understand is essential. And then some data suggest reduction in retinopathy of prematurity. And then again, all the benefits that we see with term babies are additive to the preterm baby. So we have seen some trends that have occurred over time, which are favorable. One of the big trends is the reduction of preterm formula and the increase in all the human-related products like donor milk, an increase in mothers being able to pump their own milk or provide their own milk, and a change in the fortifiers from intact bovine to a hydrolyzed form, which we are still grappling with what benefit that offers. And then a rise in the early oral colostrum care, or often they call that oral immune therapy. And then a rise as well in human-based fortifiers of human milk. And so right now we've moved since the past from one where initially there was a lot of initial attempts with human milk and found that that wasn't sufficient to grow the preterm baby, and then a period of time where preterm formula was really the only option. And then we moved to one where we took mom's own milk and then fortified with varying, initially very fragmented components, and then much more of a single intact version of a fortifier of human milk to other products that are human milk derived that are acting as fortifiers. So now we have a rich complement of products that can add onto mom's own milk to grow babies optimally. So when you're thinking about your system, I think what I see is often very, very much missed is this idea of high reliability. And in quality improvement, we not only want change to happen, but we want a change to happen and for that change to be reliably different over and over again. So on the right column, you'll see what it means to have a high level of reliability, you know, at sort of the 95% level. And your system then needs to be built with tools and mechanisms so that, and redundancy, so that the system is reliably producing the outcomes that you want in that particular process step. So if you want a standardization of a feeding protocol, how do you make sure that the compliance to that protocol is consistent, and what can you do, either building something into the electronic medical record, or what I'll argue on the left, and that what we found in a number of exercises is the high reliability of your nutrition, your dietitian or your lactation consultant or your feeding therapist. That individual can, if they're there on rounds and they're there consistently, can provide an amazing amount of reliability to delivering the nutrition practice that you have decided as a system to deliver. The other way or mechanism to really build in reliability is to remember to round around nutrition on a regular basis, whether it's weekly or twice weekly, whether they're called nutrition rounds or timeouts, as we called in the collaborative. Establishing a regular time when the nutrition information is surfaced and the feeding information is surfaced, so that discussion can be done and the reference can be made to your protocols or algorithms and guidelines that have you set to be the standard, allows for correction and checkpoints to enable that consistency to be more thorough. Having really clear set growth trajectories and having that built into your system, whether it's in your progress note or it's in your growth chart itself, is really, really important. The other thing is, if you don't measure it, you don't know what's happening. And we struggled initially, and we still struggle a little bit trying to get accurate mother's milk volume. So when mom pumps and brings her milk in, this is often invariably recorded. So if you're trying to establish good, optimal mother's milk volume, you've got to have this incorporated in a way that the data is visible and then it's actionable for you. Our electronic medical records are continually getting better, and I think we can see the future where the system serves us more than we have been serving the system. So really looking forward to how the future may be. So I'll make a call out that the dietitian is foundational, And one of the challenges right now is that there's often a lot of stress and a lot of pressure to kind of reduce the role of the dietitian in being able to offer the appropriate amount of care for the right ratio of patient to staff. And that challenge is really difficult, because I believe in neonatal nutrition, the dietitian acts as a high reliability factor and is essential, because we don't have as much nutrition knowledge in the providers, certainly in the providers and the nurses, the bedside nursing. The level of nutrition knowledge needs to be very high in order for us to deliver. So I think thinking about your own system, what is your high reliability team, and what are the high reliability processes that you have in place? So I'm going to go through the 10 steps really quickly to try to give you a sense of and some high points around the importance of these. And these are not fixed in stone 10 steps. They're steps that allow you to build your own system, and you're open to kind of identifying others that may be able to help you in your own system develop the best delivery of nutrition, and particularly human milk nutrition. So the first one is to have policies in place that are directed to nutrition and directed to the human milk, and have that available to all the staff as well as to the parents. So thinking about, what do you require? What do you want to script? What do you want to have on paper? And there are many examples of what's listed here, is identifying from beginning to the middle to the end, identifying all those things that can be beneficial to be available and visible, so that there's a common shared model of what are we doing, what is our unit doing for skin to skin care, what is our unit doing for feeding intolerance, and being able to build that in so that more and more consistency happens across multiple providers. So taking some time in, and this is where the team effort comes in being able to map your unit. Do you have all the different steps covered? Is it written on paper? Are there algorithms where there needs to be algorithms, or guidelines where there needs to be guidelines? And how much of that is visible and available at the bedside? Because it's no benefit to have all those wonderful detail in a binder that sits in a corner or in a box. It needs to be available and accessible to the team. The second thing that I think became more important, it wasn't originally in our first 10, is this idea of bringing the family, and in particular the mother, into the center of the care of the baby. And we found this really important, not just for how much does my baby weigh, and following how the baby's feeding, and all the way to breastfeeding. The family needs to be at the center of that, and being able to not only provide the education, but to listen and to hear the voice of the mother and the family about all the different aspects when it relates to nutrition, and being able to bring the mother up in medical education, so medicalize her parenting, but also being able to tune into how she can advocate for her baby as it relates to growth, and as it relates to breastfeeding and oral feeding as you go along. So make a concerted effort to kind of figure out, where does the mother fit into the whole pathway. So having parents present on rounds, and having their voice heard during rounds or afterwards even, to be able to understand what their concerns are, is really important. The third one is to really drive home that human milk is essential, and that it really is the foundation of preterm nutrition. And even more so, as we're now seeing a huge threat to the availability of preterm formula with the recent lawsuits, this is even more essential for us to get this right. So looking at your own system to drive an all-human diet. And one of the initial drivers, I'll be honest, was trying to reduce necrotizing enterocolitis. And this is a powerful image to try to help clarify why we think human milk is so essential and important for disease like NEC, which is threatening our babies in the NICU. So showing that human milk acts like a drug, and that the more you give human milk, the more you reduce the chances of developing NEC is a really powerful message to parents and to staff. So take that kind of visual and that kind of messaging to kind of hammer in a few nails so people repeat that mantra is really important to be able to capture why the change is necessary. The other thing that became much more available, certainly since when we initially started to standardize practice, is this whole area of donor milk. We recognize if we were advocates for mom's own milk, that there are many situations where donor milk needs to be available to fill the gap. That gap was very large before, and it's gotten better as over time we've seen moms produce more and more milk on their own, but still we have a large gap. And so the availability of donor milk and the increase in the availability of donor milk, we've had over 100 years of history around this, but seeing that in the country we have an increased number of banks as well as increased ability to service any of the states in the US as well as the provinces in Canada. We now have no excuse to say that we don't have access to donor human milk. And then when you drive donor human milk over, in addition to mom's own milk, you need to be aware of the differences. So there's still net overall benefit to donor human milk, but we know that it's that on the pro side that it's human specific, so we think that's good. We know that it is available to fill that gap, but it's processed, and that processing affects some of the factors, but still, despite all its manipulation and processing, we still have a significant amount of bioactive factors over and above regular formula, and that it still has the a positive in its current form. And there may be some advantages that's coming out with newer work that pooling different mom's milk might be able to take some of the advantages of some mom's milk and average it out over a collected pooled sample. On the negative side, we know that the quality of the milk is lower because of all the processing. All the cellular components are lost, all the probiotics are lost, and there's just, because of the timing of collection, there's less protein available in general, and then the sort of the digestive or enzymatic activities like lipase is absent because of the heat treatment that reduces that. And overall, there's lower bioactivity, as well as some nutrient components such as in salts or micronutrients and vitamins that may be reduced that are important to recognize and to follow. And then the lack of mother to baby specificity, especially when we're thinking about the immune system, may be important, but not clearly defined. The level of quality of human milk is another thing to kind of reference, because as you get more and more into human milk, you need to be honest about the quality of the milk, as each time you do something to the milk, whether it's storage, cooling, freezing, or in the case of donor human milk, when you're processing it, you change the quality of that milk. And what does your system do with that quality? Does it triage accordingly and weigh certain forms of milk higher than others in terms of quality and in terms of what you use first? Again, those are things that need to be built into your system to be able to be beneficial. And knowing a little bit about how donor milk is processed would also be really helpful, because it's not just black box, that you recognize that it's safe, there's been a long history of use, and that it goes through these multiple steps of processing. And at the end of the day, we have a very safe product that has been used repeatedly and with really good reliability because of the way it's been able to be protected through that process. And we were lucky that we've had two major studies that help support the use of donor milk. The first is the Canadian study by Debbie O'Connor and her team in Toronto called the Domino trial. And in that study, almost 400 babies were involved, and there was a target to see if there was an improvement for those babies that were supplemented with donor milk versus formula. to see if a difference in 2-year neurodevelopmental outcomes was present. They did not find that, nor did they find any big anthropomorphic or growth differences. They did, however, see differences in the overall neck rate, which was important and supportive of this idea that even with all that processing, donor human milk has those protective effects against neck, as we see with mother's own milk. And then corroborating that was the NICHD study by Aterkalesi and all, who basically showed a very similar outcome, lower, no difference in the 2-year outcome, but as far as neurodevelopment, but did show lower neck rates overall. And that's, but no difference in mortality. That's important. They did see a difference in the weight gain, which was slower in the donor milk group, and that's important because if you look carefully at how donor milk is processed, there may be risks for the nutrient components and the nutrient content of that. So that was an important outcome. But those are the 2 big studies. We're probably not going to see any major donor milk studies, but they give us evidence to support that practice. Standardizing enteral feeding procedures, I'd say, is a really important thing. And I think most people get this right, so I'm not going to spend a lot of time. Do you have a guideline? Is it visible? And have you demarcated exactly how it works? Is it slow and steady? Is it available by the bedside? And is it driven consistently so that a high percentage, at least 85, 90% of your babies are following that protocol? Implementing that is essential. Besides emphasis of mom's milk, looking at growth, I think is another huge target. Being able to have a growth chart. Now we have electronic medical records that really record this well and allow you to follow the trajectory of the babies is really, really important. But a lot of times what we see is that there's a reactive tendency that the system waits till the baby fails and then adds nutrients and additional calories. What we really want is to avoid those failures, because repeated failures in growth are cumulative, and it's very, very hard to catch up on cumulative deficits. So having a protocol where you anticipate poor growth, maybe it's growth restriction, maybe it's donor milk use, you are trying to build a system so you're proactively growing the baby. So thinking about that in your own system and how you would make a difference is important. And as I mentioned in the beginning, when people jumped on trying to standardize feeding, a lot of the energy is at the beginning. So fewer people have a consistent, standardized approach to when babies are failing. When the fortification, what to do when a baby's not growing, do you fortify, do you add more formula, do you add different modular products? How is that done in your system and from provider to provider? There's a lot of variation in practice in this, and recognizing what you add also needs to be carefully thought out. Is it lipids? Is it carbohydrates? Is it protein? Is it multi-component? And then every time we juice up that human milk, we're increasing osmolarity, which may have increased risk to the gut. Maximizing mother's milk production is another key vital component. And so knowing in your system, how do you deal with mother's milk production? And one of the key things is is really at the delivery site, is when a mom comes out delivering a baby, what do you have in your system to provide support, the necessary equipment, and the right ability to measure your ability to identify who is getting their pump and getting initial production. Certainly within the first 6 hours is now the gold standard, as we have good data support that early, not really, really early, but early within the first 6 hours is really essential. So what's your system got in that first 6 hours? And what is your approach? You could spend a whole talk just on pumps, but what is your ability to manage pumps? Because if you don't have a good way of managing pumps, having the pump available to every mom in every form, whether they're hospitalized or they go home, you present a huge barrier for that mom to be able to produce the milk that you want for that baby. So going through each of these steps in your system. What is their insurance? Where are the gaps when moms, like we have a big gap when moms don't have insurance, they don't have access to good pumps. And so having a rental system, having a loaners, having a pool of donated pumps may be the way to fill those gaps. But without analyzing it, you may really miss out on opportunities. Next is quality and safety. And I love this diagram because it really talks about milk trafficking as opposed to drug trafficking, because we own it. Once mom hands us the milk, our hospital system now owns all these steps, and more process steps mean more responsibility. So what have you done and your system done in each of these steps to ensure the quality and the safety of that milk every time that milk touches a different surface, touches a different handler? Each of those are steps where you can drop the quality of the milk. And number 8, encouraging skin to skin and breastfeeding. This is huge because you can't just suddenly get to a point where, oh, now it's time for baby to feed, or now it's time for baby to breastfeed. It starts early. The mother-baby bonding has to be early, and that really sets up the stage. So what's available in your system to allow consistently mom and baby to be together, mom and baby to start early non-nutritive sucking in your system? And who are the players that help that mom establish those early successes? And how is your system built to get preterm babies breastfeeding on their mothers? A lot of times this is a lost step, and having a very consistent approach when they have early address to the breast before nutrition really flows, and then slowly with time as they're learning oral feeding progression, they're gaining these other skills as well. The other area that's really not well standardized is oral feeding progression. I think we've gone better. This is an example of what we developed in San Diego, but it's really an example of putting everything on paper so that there's consistent address of when babies are progressing along oral feeding and when to slow down and when to speed up. Do you have a system that is consistent and it's driven by the baby? So we like to call that infant driven or cue-based feeding. And we know that the literature supports this idea. The more you can build in a process accountability, the babies are going to do better. And then the final thing is that nutritional discharge. Getting babies home is a huge gap, and it's still a huge gap even after many, many years of people addressing. And why is that? In the intensive care unit, we provide so many services and so many resources to support that baby and that family. But when they go home, there's a huge loss of that support system. It's very common for that handover to be poor, and on a nutritional level, we don't always hand off the right nutrition details and the right breastfeeding and lactation details in order for success to occur at the home, just as it was in hospital. So what do you have in place that's consistent that allows that handoff to be effective? And so so those are the 10 high points on the sort of the steps to standardize. I would encourage you to understand all your processes. So take the area that you're working on and break it down like in this process map where you can start to see exactly, this is one for how we started to use probiotics, understanding how you implement all the way down to ordering the probiotic to delivering it to the babies and what are the requirements and where in that system are there potential reasons for failure. So this is sort of a failure in addition to looking at the process, you identify the failure steps. And part of that failure step, you're able to create what's called a Pareto diagram, gives you these beautiful top causes of failure. And rather than spending all your energy on all the different reasons, you can spend your energy on the top 2 or the top 1 even, and really kind of helps narrow your focus. The last sort of tool is to be able to use a very specific approach. And the SMART aim is one of the things that I think is very helpful. In other words, there's so many problems to solve, so many things to standardize. Start with one. And with that one, make sure it's specific, measurable, actionable, relevant, and time-bound. and build that into what is called a key driver diagram. And our teams use this repeatedly for every change because it's a working document, it's a living document, and it allows the whole team to first understand what's our goal, what are we trying to achieve, what's our aim in a very time-dependent way. But it also allows you to understand your system. What are the drivers that lead to that particular outcome that you're looking at? And then what are the interventions that you're working on? You can't work on all the interventions on the right, but start with one or two. And then as you get success with them, you can move on. And coming back to this key driver diagram is really helpful to address a specific problem. So final things is just getting, putting in the effort to build your team. There's no success without the team. You need to identify who are the stakeholders, who are the people who are the champions who are really vested in this, including the parents, and then making sure that the conversation is flat in terms of hierarchy and having ability to encourage as much conversation and discussion when you're addressing a certain area. And then work on things that you care most about. And in addition to following your key driver diagrams, but start small, don't swallow the whale, and be the team. And what we talk about in our group is trying to move from me medicine, which was really the old way of medicine, to we medicine. And this is going to be much more successful. So final points is just that the underlying message that's really powerful is that human milk really drives the biggest intervention that we can do in the NICU, and all the sort of the process that we put in place are how to support human milk to grow babies the best over time. And then final sort of PR message is that parents matter. And so this organization called Next Society, which I have the pleasure of being on the advisory board, has been tremendous in being able to support mothers and families affected by NEC in particular. And they have had several conferences that our institution supports to try to bring parents and all stakeholders together to reduce NEC. One of the big messages is around nutrition and human milk feeding. And then final promo is just this we have a biannual conference called the Advances in Neonatal Pediatric Nutrition. I encourage you to join our virtual conference next winter, February 6th and 7th, and lots to there. And I've listed some references there. And I'm going to end now and give the remaining time for questions if they can be posed to me. So thanks for your attention.
Perfect. Thank you, Dr. Kim. We'll definitely begin answering questions submitted during today's presentation. Remember, you can still submit your questions through the questions pane in your attendee control panel. Our first question, Dr. Kim, is, you mentioned that freezing breast milk destroys the mammalian components, i.e. stem cells. Is that just for premature infants, or does this occur with all breast milk, no matter what gestational age a baby is born at?
Yeah, that's a really good question. So we know that mammalian cells are fragile because their cell membrane does not have like a cell wall that's present, say, with bacteria. So if you take any mammalian cell and you freeze it, remember, water, when it turns ice, expands. So that is exactly what happens with mammalian cells if you freeze it. So it doesn't matter if it's preterm milk or term milk, freezing disrupts and destroys any mammalian cells. The bacterial cells are protected because they have a tough cell wall. So even with freezing, they're able to contain that expansion and survive. It's a good question.
Perfect. Thank you. Can you provide specific examples of how your institution has successfully implemented a system of human milk nutrition care?
Yeah, so a comprehensive approach is quite expansive. You've got to develop. So what we did when we were in San Diego, and ironically, the spin program that we had in San Diego, some of those components were migrated and taken to develop here in Cincinnati. The approach is kind of like what I explained, is looking at that whole spectrum and taking the processes and making them into specific algorithms or guidelines. So in our center, for instance, we have a small baby feeding protocol, we have a moderate sized baby feeding protocol, a large baby feeding protocol with, different components. We have, if you use donor milk, we need to make sure that we boost, support donor milk over and above, because we know that there's some deficiencies, and having that kind of strategy built in. So multiple components require you to kind of open up, break it up into processes, and then put it down on paper. And we're happy to share any of our components if you want to, either through this webinar, reach out to me. Happy to connect you with our nutrition team and share any of our documents. The toolkit that listed before is a good starting place for some of the work that we did in San Diego, but also other groups that have put together their contributing documents and policies, and that's a good way to start if you're at the beginning or wanting to address one thing in particular.
Awesome, thank you. Do you have guidelines for the amount of breast milk the infant is given, including the Academy of Breastfeeding guidelines?
So I'm not quite understanding the question, but I think how the ultimate goal, and this is where the challenge right now is going to be, the ultimate goal is to try to provide the base milk. The strongest evidence we have is to provide the base milk as mom's own milk or donor milk as the base, as long as you can go. We know for outcomes like NEC that going out as far as 34 weeks at least gives you protection. Arguably, you could go further and you may have other gains that are not as well described, but there's definitely supportive evidence to be human as the base all the way out to there. The fortifier that we add on top, which now we have two types, are either bovine-based or human-based. We have evidence to support either one of them as being beneficial to boost up nutrients overall density and some of the micronutrients, but to be able to provide that all the way across as well. The distinguishing features between human derived versus bovine derived is less clear based on the last few studies that have occurred. There's a Canadian study and a Swedish study, both of which did not show a big difference when you did a comparison. The caveat, those studies were done with the old bovine fortifiers, so it's hard to know, since we've now switched to, we think, better hydrolyzed bovine fortifiers, so that maybe the difference is really not that appreciable between those two types of fortifiers. But the goal is to have human base all the way across as long as possible as far as provision. Now we're also seeing on the other end, in the term area, that there's a lot of supplementation that's being used with donor milk as a bridge. We also use donor milk as a bridge in the surgical population, in the term or the near term babies in a level 4 NICU, to try to help moms, because it's often very difficult for those moms to continue to just initiate and continue breastfeeding, but using that as a bridge to help support the human milk diet even in those patient populations. So that's increasing as well. We certainly have practices in those two areas in addition to the preterm area.
Perfect. The next question first starts off, great presentation, thank you. I'm co-founder of the Mother's Milk Bank of Tennessee. Donor milk is accepted from bereaved mothers. Where is a good research center for this milk that is not screened for pasteurized?
So that's a really good question. So we have amazing moms that are altruistic, whether they have living children or in the sad cases of bereaved. There's a lot of milk that's donated to the banking community. Each bank has some resources, like for our Ohio bank, for instance, we offer the ability, they're in Columbus, but we have a milk repository within Cincinnati Children's, so we would be happily take milk that does not meet the criteria for donor milk processing, to be able to use that for research. In my old group in San Diego, they also have a Human Milk Institute that has a really good pipeline for what we call research milk. And there are a number of other centers that have that. The bigger banks tend to have that access, but I would encourage you to go through Himbana and ask, but definitely I would say our center and San Diego definitely are big. I think Austin as well in Texas is another place that has research pathways for excess milk.
Perfect. Has there been any research into oral care with colostrum as a factor to preventing NEC in VLBW babies?
Mhm. Yeah, so I think the practice of oral immune therapy or oral colostrum care has really jumped fast. So I'd say definitely more than half the units are doing that practice. The data lags a little bit. There's not clear data to say that if you did oral colostrum care, that you are going to prevent neck any more than if you didn't use it. Now, the reason is not that there's no effect, it's just there's not been a study to address that question particularly, because remember, neck does not occur that often. So you'd have to have a very, very large study to be able to demonstrate that difference. Do I think it's beneficial? I think for sure there's evidence support that there are components in colostrum that actually get absorbed in the mouth, as well as providing some nutrient and prebiotic support in the gut. So I think there's definitely positive short-term benefits that can be derived by having that oral therapy, but we don't have evidence that in of itself that it's reducing neck. But we have, on the flip side, we do not see any evidence for harm either. So I think the practice, even though it's getting ahead a bit of the evidence, the practice seems to be very safe. And it's a way for people to get moms starting to pump and to establish early milk production. So I think it's a really important thing for people to set into motion and then standardize in practice.
Wonderful. What are some of the most effective quality improvement approaches you've seen in NICUs for enhancing human milk nutrition performance?
Yeah, so I think the things I really like is because one of the challenge I think with every group that have champions is that they put a lot of energy and they try to make a change in a process or multiple processes, and they show improvement. And one of the dangers is that once they take their eye off that and go look somewhere else and focus on something different, that first thing that they fixed and got better often may not sustain at the same level. So this concept of high reliability is what I really want to keep emphasizing. What can you do, like building a feeding algorithm into your electronic medical record, such that when you order the feeding algorithm, the computer just allows for that process to take place, so that there's no variation that gets imposed by different providers. Having a reliable dietitian on rounds or routinely screening, so that you apply a set your set guidelines, what you think you want an ideal situation to be. They could be kind of the police of that process, of those processes. So building in high reliability with a really reliable dietitian, having EMR, electronic medical record, hardwired steps, so that some of those algorithms now become part of the order set, will enable you to have greater reliability and take away some of the variation and the participation and the extra effort of the, say, the champions of the team to constantly be checking. And also leveraging your electronic medical record for outcome data. Now we're getting more and more report outs from the electronic medical record. So this is a really good way for you to build your system, so you get data that tell you, we're getting better. We started to do this, look at compliance, look at different process steps, and have the readout quickly, so that you get feedback, and then you can act on the feedback and build better processes as you go along. So those are important ways that we certainly found. The more you create the reliability component, the more capacity you have, the more ability to do additional, address additional steps or processes in your system.
Perfect. We have a couple of more questions remaining. In your
Mhm.
experience, in your experience, how does an infant-driven feeding program support an exclusive human milk diet?
Mhm. So I think the most important thing when you get to that oral feeding step is that are you still having mom provide milk? Sometimes moms struggle to get their milk production all the way in that by the time a baby gets to 30, 32, 33 weeks gestation. So first is support that mom so that milk is still flowing. You can certainly still use donor milk, but having mom's milk still present is really crucial. And then the way the oral feeding progression works is that you really go slow and steady and go slower initially so that you really establish good quality feeding. And I think what we've learned with cue-based or infant-driven feeding is not to just program in a volume and let the baby feed that volume, is sense how the baby is feeding. And so we've gotten better at knowing what I call the start signals, recognizing, oh, this baby's cooing and ready to feed, and putting in either going to the breast or putting a bottle to try to establish some feeding. What we're not good at still is knowing when they don't have an interest or actually the opposite, they're aversive to that feeding. So I think the stop signals need to be more attention needs to be placed on the stop signals. But certainly we've gotten better at the infant-driven piece, the cue-based piece, but we need to figure out better stop signals. If you use breastfeeding as one of the early feedings, an empty breast and putting baby to that breast, that's a wonderful way for a very slow approach for that baby to establish early suck and swallow and establish breastfeeding at the same time.
Perfect. And I believe this may be the last question. With a human milk diet, are there specific lipid emulsions or probiotics that you recommend for preterm infants?
Yeah, so I mean, right now, the best way we can deliver the human milk diet is to have mom's milk and the preface is that mom needs to be healthy and she needs to be on a healthy diet and hydrated and so forth. But taking that mom's milk, and if you need to, if donor milk is available, being able to calibrate donor milk depending on your source, because different banks give you different quality milk. So also making sure that that milk is coming into you and you're able to correct for changes or optimize it in a proactive way so that mom's milk, donor milk if it's present, and then topping it up with the bovine or human-based fortifiers is really the composite of what would be ideal, and do that as long as possible throughout the hospital stay.
Okay, Dr. Kim, I believe that is all the time we have left for questions. Did you have any final words before I read my exit?
Yeah, I would just say just a call out to everyone is develop, get a handle on your team. Figure out if you it doesn't have to be a huge team, but find your champions in your team and start there, start small, build the processes up and address something that's size specific and then work from there and lean on everything that's been produced, published and sent out there in the community. You don't have to reinvent the wheel. And then final thing is think about high reliability because many of us just don't have enough time and energy in the day. We need to build systems that are reliable and sustainable as we keep building better and better systems.
Wonderful. Thank you so much, Dr. Kim, and thank you everyone for attending today's webinar, Achieving High Reliability Growth and Nutrition in the NICU. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view the recording of today's webinar. A reminder that continuing education certificates will be sent to the email address you registered with by Friday of this week. On behalf of Madila and Dr. Kim, thank you for joining us today and have a great rest of your afternoon. Thank you.